Welcome everyone to this webinar today, and this webinar is on modernizing the approach to the dry eye disease. We have a galaxy of speakers with us today. Major General Dr. J.K.S. Parihar sir, who is the President of the Eye Bank Association of India. He served in the Armed Forces for about 34 years, and he's the Additional Director General of the was the Additional Director General of the Armed Forces Medical Services, Professor and HOD at RNR Hospital, Delhi Cant, and Professor of Ophthalmology at AFMC Pune. Currently, he's affiliated at Center for Sight, New Delhi, as a senior consultant at Head Academics and Teaching, and is Professor of Ophthalmology. He has published 102 research publications in national and international journals and presented 705 research papers in the various instruction courses at national and international level. He's authored several books, and his achievement was endorsed as a world record by Limca Book of World Record in 2013 for performing phacoemulsification cataract surgery at the highest altitude of 14,106 feet. He has more than 40 national and international professional and distinguished service awards in his credit, and the President of India conferred Sena Medal, which is a very coveted award, bar to VSM and VSM upon him. He has also received a coin, IRSI, and DOS. We welcome you, sir. And I would now request Dr. Rajesh Sinha, the co-moderator with me, to introduce the next chairperson.
It gives me great pleasure and honor to introduce stalwart in the field of cornea, Dr. Samar Basak, who is the director and founder member of Disha Eye Hospitals, Barakpur, Kolkata. He is head of the department of cornea in that hospital. He is a senior consultant for anterior segment diseases, cornea and external eye disease, and eye bank services at Disha. He has held various positions, which includes he has been appointed by the Cornea Society of America and Sight Life International as one of the 5 cornea surgeons worldwide for cornea skill transfer. He has been principal investigator in national and international drug trials, phase 3 and phase 4. He has nearly 100 publications in journals and books and has been recipient of multiple international awards, also the past president of Eye Bank Association, and is an avid academician. We welcome Dr. Samar Basak.
It is a pleasure to introduce our co-chairperson, Professor Radhika Tandon, who's Professor of Ophthalmology in the Cornea, Cataract and Refractive Surgery Services at RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi. She's currently the head of the unit of Cornea, Cataract and Refractive Surgery Services, as well as the Ocular Oncology Department, as well as Low Vision AIDS. She's chairperson of the Low Vision Services at RP Center and also the immediate past president of Eye Bank Association of India. She has to her credit numerous publications, papers, book chapters, and textbooks. She's also the co-author of the Parsons, which is read by the undergraduates all over the country. She has more than 350 publications with 82 total impact factor, 1.88 average impact per publication, 4,254 citations, and an H index of 33. She's been conducting various instruction courses and has been invited faculty at various national and international conferences. And more importantly, she is a great teacher and mentor to almost all of us. So we welcome Professor Radhika Tandon.
It gives me great pleasure to introduce, although she needs no introduction, but it gives me a great pleasure to introduce Dr. Namrata Sharma, who is professor. In his free time, he loves to play badminton and is an avid sports enthusiast. So that is something which we all should know about him. And so we welcome Dr. Bhaskar in this webinar.
It is always a pleasure to welcome my batchmate, Dr. Nikhil Gokhale, the topper of our batch, in fact, during MD at RP Center, All India Institute of Medical Sciences, New Delhi. Currently, he is working in the Gokhale Eye Hospital, which he owns in Mumbai. He has a keen interest in corneal infections and ocular surface immunology, and he's been a speaker at various national and international platforms. He's been the member of editorial team of the Indian Journal of Ophthalmology and editorial board member of Journal of Clinical Ophthalmology and Research and reviewer of the Cornea Journal, Journal of Cataract and Refractive Surgery, and several other international journals. He is a founder member of the Executive Committee of the Cornea Society of India and founder member of the very successful Cornea Club in India, the Mumbai Cornea Club, which is running successfully for last more than a decade. He's also a member of the American Society of Cataract and Refractive Surgery and has been former secretary as well as president of the Bombay Ophthalmologists Association. He's, to his credit, several awards, which include the V.K. Chitnis Oration Award by Maharashtra Ophthalmological Society for his exemplary work done on infectious keratitis. And he's also been the past president of Cornea Society of India. Welcome, Nikhil, to this scientific forum.
It gives me great pleasure to introduce Dr. Sunita Chaurasia, who is consultant cornea and anterior segment at L.V. Prasad Eye Institute in the Refractive and Pediatric Cornea Services. She's the director of the Ramayama International Eye Bank. She did her fellowship in cornea and anterior segment at L.V. Prasad Eye Institute, Hyderabad, and then did her overseas fellowship in advanced corneal procedures at the renowned Price Vision Group, Indianapolis, USA. Her clinical areas of specialization are advanced corneal surgery, cataract, refractive surgery, pediatric corneal surgery, infective keratitis, and eye banking. And her basic research interests are corneal endothelium, Fuchs endothelial dystrophy, and other endothelial disorders. In 2014, she received the Achievement Award at the American Academy of Ophthalmology, and she has been publishing many articles in peer-reviewed journals, and has authored several books and presented papers in international and national forum, and is a reviewer for several national and international journals. So we welcome Dr. Sunita Chaurasia, who is truly a very good academician.
So this is the agenda of the meeting today. And before I request Dr. Bhaskar Sreenivasan to present his talk on practical pearls of using fluorescein staining in dry eye disease management, I would now request our president, Eye Bank Association of India, Dr. J.K.S. Pariyar sir, to say a few words before we commence the program.
Thank you, Professor Namrata and Rajesh, for organizing this wonderful webinar on DED. DED looks to be dry subjects, but I know it is one of the most difficult tasks to handle in cornea and all anterior segment diseases. So this topic has been generated interest by these two duo for last couple of years, and we're seeing this spectrum of galaxies, those who are participating in this webinar. I am very sure that all of us will be greatly reached by deliberations. Before I hand over mic to Professor Namrata, I'd like to add on 3 words about Professor Radhika and Dr. Bhasak. I had a good fortune to work under them as a office bearer of EBI, learned a lot from them. And Radhika is a very dynamic, pushing person who has literally taught me how to handle the Eye Bank Association. And last but not the least, about Dr. Bhaskar Sreenivasan, probably you may not be knowing that I have a unique, distinct privilege of being his teacher in FMC. And then that time we predicted that Bhaskar will do wonders. He got more than 85% marks in the Pune University exams, and his contribution and the way he has come up is phenomenal. I am really proud of Bhaskar. He is for me bigger than Sachin Tendulkar or as a coach. Thank you very much. I hand over to Professor Namrata, who has been my now she is my mentor. She is my mentor, and she was my partner in a tough time during my fellowship in 95, 96. So all brunt used to be her, which used to come from Dr. Dada and Dr. Angra, and I could learn a lot from them. Thanks a lot for inviting me and share this session.
Thank you, sir. We would also like to welcome Dr. Rekha Ganchand, who is our South Zone member from Eye Bank Association of India. and a senior consultant in Bangalore at the Orchard Eye Clinic. So welcome, Dr. Rekha. And I think we'll begin the first talk by Dr. Bhaskar. We also have with us Mr. Ganesh and Ms. Raki, both of them currently involved with the Eye Bank Association of India and helping in the managing the admin part of it.
A very good afternoon, one and all. Can I share my screen?
Yeah.
Just a second. Yeah, a very good afternoon to one and all. I would like to thank the Eye Bank Association of India, AIOS, and Santen for the opportunity. And I would like to thank Major General Perihar for the kind words. Whatever I have learned so far is courtesy my teachers, both at AFMC and at Shankar Netralaya. So coming to the topic at hand today, we're talking about the practical pearls of corneal staining. So we are going to be looking at staining, what its role in the current dry eye algorithm. We are looking at normal tears and the ocular surface. We are going to be looking at certain anatomical and pathophysiological basis of corneal staining and the various types of dyes that you can use to stain the surface and their properties. So when you compare both a DEUCE 2 definition versus an Asia Dry Eye Society definition, basically the DEUCE 2 tells us that there is ocular symptoms, there is tear film instability, there is a symptomology questionnaire, and of the various questionnaires that are available, the DEUCE 2 has given preference to the OSDI and the DEQ5. The OSDI is more commonly used, but the DEQ is also useful because it's much shorter as compared to the OSDI. And once your symptom questionnaire is done, then you look at the homeostasis marker, which basically includes the non-invasive breakup, or if you don't have access to a machine to give you a non-invasive breakup, then you can look at the fluorescein breakup. You look at the osmolarity and you look at the corneal staining. And based on these homeostasis markers, you decide whether the patient has a primary aqueous deficiency or has an evaporative deficiency, or as in most cases has a combination of both aqueous and evaporative deficiency. You try to grade the severity of each component, and that is what tells you how you are going to manage these patients. It also tells us the order in which the test needs to be done. So if you're doing a non-invasive breakup time, you can do that first, followed by the osmolarity, followed by the corneal staining. But if you're going to be doing a fluorescein breakup time, then you need to do the osmolarity, then the tear breakup, then the ocular surface staining. So when you look at the Asia Dry Eye Society, it basically gives you a questionnaire, symptom questionnaire, whichever you want to use, and it talks about a tear film breakup time. Now, when you look at the DEUCE 2, it uses a value of less than 10 seconds in its diagnosis of tear breakup time, whereas an Asia Dry Eye Society uses a value of 5 seconds. So a symptom questionnaire along with a decreased tear breakup time gives you a diagnosis of dry eye, and the pattern of breakup can actually tell you about which component is less, whether it's an aqueous component which is less, whether it's mucin which is less, or whether it is an evaporative dry eye. So in both, whether you say DEUCE or you say Asia Dry Eye, tear film and surface staining is a very essential part for you to diagnose dry eye. So this is basically the flow. You will probably ask the questions, and that gives you the symptoms of the patient. And when you're looking at signs, you're looking at osmolarity, breakup, fluorescein staining, Schirmer's. Then you address the lid margins and the meibomian gland expression, because addressing or pressing the lids will alter your tear film status as such. So when you're looking at a normal surface or a normal tear film, you basically have the initial concept was a trilaminar tear film where you have the lipid, the aqueous, and the mucin. Now we know that it is bilaminar. You have the lipid layer which coats it, and the aqueous and mucin is like a common layer, and there is a decrease in concentration or an increase in concentration of aqueous from one side to the other. And this layer is stays on the ocular surface because of the glycocalyx, which is adherent to the microplicae. And the glycocalyx holds on to the aqueous mucin, and that is what retains the tear on the ocular surface. Now, when you have dry eye, when you have hyperosmolarity, there is a loss of this microplicae from the epithelial cells. There is a loss of the glycocalyx, and if there is a loss of the microplicae and the glycocalyx, then the tears cannot coat the surface, and that causes the tear breakup. And over a period of time, the epithelial cell gets desiccated and gets shed off, and that is what causes your ocular surface staining. And we'll come to that later on. So let's go to the basic question. Why do you need ocular surface staining? Well, it's needed to detect the presence of an ocular surface change. So if you look at the photo here, in a diffuse illumination, you might not pick out the extent of ocular epithelial damage. The moment you put fluorescein and then you see the extent of ocular surface damage is visible to the eye on a slit lamp immediately. It is also useful to diagnose the disease which is based on these changes. So if you look at this picture, it tells you the extent of the limbal stem cell deficiency, and it is a useful way to categorize it. Again, certain diseases like superior limbic keratoconjunctivitis can be easily picked out by the staining on that particular area. It is also useful to document the severity of the disease process and to look at resolution. So this patient with the congenital alachremia has significant ocular surface staining, and post-cautery the staining reduced, even though there's still some amount of staining on the surface. So it's a useful tool for us to monitor our patients. And last but not the least, it's a very critical component if you're doing any trial on the outcome of drops for treatment of dry eye. So what are the types of dyes that we can use to stain the ocular surface? You have fluorescein, which was first initiated in rabbits by Pfluger in 1882, and Straub used it first in humans. And Rose Bengal was started in 1903 by Shermers and popularized by Sjogren's in 1940. And Lisbon Green was initiated by Non and popularized by Manning in 1995. So what factors determine the uptake or visibility of the dye? Primarily depends on the nature of the dye, the concentration of the dye, the volume of the dye that is placed, the duration of time that the dye stays on the surface, and the use of certain excitation and barrier filters, which enable us to enhance the appearance of these dye on the ocular surface and help us identify diseased state. So with respect to fluorescein, it's available as a strip of 0.6 to 1 milligram, and that's the commonest way that it is used. A 1 to 2% solution is available, but the problem with the solution is there is a very high risk of contamination. So except for certain trials, it's not used commonly. Fluorescein absorbs blue spectrum, that is around 419 nanometers of light, and emits a yellow-green light of a higher wavelength. And it is very useful, And it is very useful for you to see a corneal epithelial damage with fluorescein illumination. However, if you're looking at conjunctival staining, because of the absence of the scattering of the blue light from the sclera, a conjunctival staining is not easily appreciated with fluorescein in the blue light. But the moment you place a yellow barrier filter, a Ratten 12 filter, it enhances the visualization of the conjunctival lesions also. So with just that one dye in terms of fluorescein, you can now look at the entire ocular surface, both the cornea, the conjunctiva, the lid margin, all without the need for a Rose Bengal or a Lisbon Green stain. But you need a yellow Ratten filter to enable you to look at the conjunctival part of the staining. So how do you apply fluorescein? Basically, it's important to apply a consistent amount of fluorescein. So you put 1 drop of fluorescein, and it is important to dilute the fluorescein with normal saline. You don't want to use a lubricating drop. You don't want to use an antibiotic drop. You don't want to use a paracane, because these will all destabilize or change your tear film parameters that you're measuring. A normal saline 1 drop, you can rigorously shake the strip so that excess water falls off, and then just apply a small amount of fluorescein at the lower lid, and then ask the patient to blink a couple of times. And generally you do the evaluation in a 2-minute period. It is very important to do the evaluation in a 2-minute period, because if you delay too much, then in a diseased state, fluorescein can go into the corneal stroma, and then your epithelial lesions will be less well appreciated. So what are the cases that you would use a fluorescein stain for? If you're looking at an ocular surface examination, fluorescein not only helps you to look at positively stained areas which are seen like this, but even negatively stained areas like this can be picked up by fluorescein. A negative stained area is an area where the epithelium is slightly elevated, could be because of EBMD, could be because of recurrent corneal erosions. But both a positive and a negative stain is useful information as far as fluorescein is concerned. It also helps you to know the tear meniscus height. It helps you identify conjunctival folds or conjunctivochalasis. It's useful for contact lens associated staining or identification of a tight fit. And obviously, if you're looking at a perforation, then it helps you with Siegel's test, where you can see the fluorescein leak very well. So when you're looking at a dry eye disease, the two main parameters that we are looking at, which is going to form the basis of my talk today, would be the conjunctival and the corneal staining, and the tear film breakup, which is basically both the breakup time and the breakup pattern, and the relation of this breakup pattern with blink. We also now have the option of specifically looking at the flow of tears from the lacrimal gland. So you can use fluorescein to coat it over the lacrimal gland area and see the amount of glands which secrete, the gland openings which secrete the tear, which is now being looked at to identify cases of dry eye. So when you're looking at staining, also you need to know there are patterns of staining. So if you have a diffuse staining, you're probably looking at some kind of a viral conjunctivitis. If you're looking at an inferior staining, you're looking at some kind of a lid margin related issue, or a lag of thalamus, or a trichiasis, which is causing a staining in that particular area. If you're looking at a diffuse interpalpebral staining, you're probably looking at dry eye or a neurotrophic state, which is causing the staining. If you're looking at a superior corneal and conjunctival staining, you're probably looking at a superior limbic keratoconjunctivitis. A classical 3-9 o'clock staining is more often seen with contact lens related issues, and a specific lower lid staining can be picked up with respect to either a toxic medicamentosa or a mechanical or a meibomian gland dysfunction. So coming to the anatomical basis as to why we get a staining, in a normal corneal epithelium, there are tight junctions between cells, and there is the glycocalyx which coats the cells. This prevents the fluorescein from going into the cornea. Now, in a diseased state, when there is a breakdown of this glycocalyx, or there is a breakdown of these tight junctions, you can expect fluorescein to enter into the cell, and that is what happens in a diseased state. So just going to a diagrammatic representation, you sometimes do see something called as a transient epithelial stippling even in a normal eye. So that happens during the process of apoptosis. So the first figure shows you in a normal state, there is a glycocalyx which is coating the surface, and there is these tight junctions which prevent the fluorescein from entering. The moment a cell is supposed to be shed, or there is apoptosis, this glycocalyx becomes a little bit weak. So that allows fluorescein to stain that cell. Now, once this cell gets shed off, you have a gap here now where fluorescein can pool. If this underlying cell has the glycocalyx which is competent and it is complete, then this is called as punctate erosions, because this cell will move up and the barrier is again anyway established because the glycocalyx is intact and fluorescein cannot go down. But if this junction is still not completely, the glycocalyx is not completely formed, you can have a staining of this cell, and this is what is called as punctate staining. And this will disappear because it's a reasonably healthy eye and it's only a transient stippling that you would see. Compare this with a diseased state where the glycocalyx is lost and the fluorescein goes into the space, and it then permeates through the gap junctions and goes at a deeper level of the epithelium, and then by transcellular and paracellular spread, it is spreading into the corneal stroma. And this is the reason in a diseased state, if you delay your evaluation after applying fluorescein, say 4 minutes or 5 minutes, you might actually see that the cornea is diffusely hazy, and you might not be able to pick out the epithelial changes as well. So pathological changes can also be seen in a normal patient when you actually use, say, this was a patient where he underwent an applanation tension, and the force used for applanation tension was a little bit more. So it's almost showing an imprint of the applanation head on the cornea. So the physical contact has damaged the epithelial cells, which is being picked up as staining of the ocular surface. Again, if you have a severe dry eye and the epithelium is not healthy, you will get a diffuse staining of the surface. If you are looking at an epithelial defect, your fluorescein pools that area, but the peripheral epithelium is healthy, so it doesn't take up stain. In terms of superior limbic keratoconjunctivitis, because of the absence of galactin, the fluorescein permeates through the conjunctival epithelium and it takes up stain. And in terms of diseases like gelatinous dewdrop dystrophy, the epithelial barrier is not intact, and that is what causes the deposits to form in the anterior cornea, and fluorescein will permeate immediately into the stroma, and it is seen much more frequently as compared to a normal cornea. So coming to the next component of the tear film evaluation in dry eye was the tear film breakup, and not just the time of breakup, we also need to know the pattern of breakup, which helps us diagnose dry eye, and this is the basis of the tear film oriented diagnosis. So they have given up a type of patterns of breakup like an area breakup, a line breakup, something called as a spot, dimple breakup, and random breakup, and they associate each types of breakup with a specific type of dry eye. So if you're looking at an area breakup like this or a line breakup, it's more suggestive of an aqueous tear deficiency. If you're looking at a spot break or a dimple break, it's more suggestive of a mucin deficiency. And if you're looking at a random break, it's more suggestive of an evaporative dry eye. It is also important to know the timing of the break with respect to the blink. So if it's a very severe dry eye, you will not see the aqueous move up at all, and you will see this staining almost immediately, which is right after a blink. If there is moderate or mild ATD, you will see the fluorescein move up, and then you will see these vertical lines come up in the lower portion, indicating the decrease in the amount of tears on the surface, and this is called as line break. If you look at these kind of spots, which happens almost instantaneously after a blink, it tells us that the tears are not able to coat the surface well. So there are issues with wettability, which is specifically related to the mucin. And if it's not as severe, you will see the tears move up, and you will see these lines more in the center of the cornea, indicating a decreased wettability of the tears on the surface. As far as evaporative dry eye is concerned, you primarily will have the fluorescein move up along with the tears. You will see the tears stabilize, and then you will see these random spots occurring. So this has to be read after the fluorescein spread is complete. So just going through some videos. So this is a severe area break where you don't see the fluorescein move up at all, and you see an area of staining almost immediately or instantaneously. This is a mild breakup where you see these lines, fluorescein move up, and gradually these lines are forming as the tears move up, indicating that it's not a very healthy tear film. You can also see the amount of tear meniscus is a little bit less. This patient, you can see the tear move up, and you will start seeing breakup in the center, because that's the area where the tear film is breaking up faster. Normally, if it's only aqueous, you will expect it to break up at the lower portion or at the extreme portion. You will expect it to be reasonably stable for a longer period in the central portion. So this is suggestive of both decreased wettability and in this case also has a mild aqueous tear deficiency. And this is a spot break where you can see these breaks. In spite of them blinking, you can almost immediately see the tears are not stable. They are not coating the ocular surface as well. And this is a random break where you have the tears film move up. Now it is tear film is stable, and then you see these random spots occurring. Now this is not a pure MGD because you do have corneal staining. If you have a pure MGD, you will generally not have corneal staining as much. Here you can see the tear meniscus looks reasonably normal, but if you look at the side, you can see conjunctival chelatic folds. You can see a conjunctival staining. So this chelatic folds is probably responsible for delaying the fluorescein clearance from the surface. That is, it is retaining the tears on the eye for a slightly longer period of time. That is why, in spite of it being a component of ATD, the tear meniscus that you're seeing here seems to be on the higher side. So coming to the other dye that we can use is rose bengal, which is primarily used for the conjunctival staining. It stains dead degenerated cells, mucin and neoplastic cells. But the problem with rose bengal is it does cause a lot of stinging when it is instilled, and you will need to use an anesthetic before installation of the dye. And you have it either as a 1% solution or as strips. The problem with strips is the fact that it is very difficult to elute from the strips, and you might actually need to take 2 strips, put a drop of saline, and that rub the 2 strips to kind of generate a little bit more of fluorescein of rose bengal, and then put it on the ocular surface. It's normally seen with a white light. You can also use a red free absorption filter to see it better. Coming to Lisbon Green, this again is similar to rose bengal, except for the fact that it is not as toxic to the surface and it is not as stingy to the patient. It's available as strip or a 1% solution. The peak absorption of Lisbon is around 620 nanometers, and this is close to the red spectrum. So if you put a red filter, your Lisbon Green taken up tissues are seen much more effectively as a bluish green color. If you are using a red barrier filter, then you can see these as a black spots. So a barrier filter can enhance the visibility of Lisbon Green stained tissue. The normal time for reading this is between 2 to 4 minutes, and it is primarily useful for conjunctival staining. But if you're going to be using a Ratin 12 filter with fluorescein, then you can probably get away without using both a Lisbon and a rose bengal as far as dry eye evaluation is concerned. So when you're looking at a corneal staining, the various steps would be, once you have done the staining, you look at dividing the cornea and the conjunctiva into zones, looking at the number of staining spots, the patches of staining, looking at the area of staining, presence of filaments, and this is then graded in various ways that you can grade it. but be clear that you will use the same staining score pattern so that follow-ups become much more reliable as such. There is no one grading which is better than the other, but consistently follow the same grading scores. So to conclude, fluorescein staining should be regularly performed in all patients, and it helps us in diagnosing dry eye, managing it, and following it up. It gives a useful quantitative as well as qualitative assessment of the dry eye disease. It's fairly simple, it's very cost effective, and requires very less time. Using a Ractin 12 filter allows evaluation of both corneal and conjunctival stain just with fluorescein alone, and it can help us individualize treatment based on the type of dry eye disease that the patient has got. And last but not the least, helps in documentation and is a very good educational tool for patients and for ophthalmologists. Thank you.
Thank you, Dr. Bhaskar, for a very nice overview on how ocular surface staining is going to tell us regarding the dry eye state, regarding the ocular surface disorder that a patient is having. Any comment from any of the panelists?
Bhaskar, I just had one question, and when you can stain, then it is good. I mean, when there is some tears, it is good. But you also deal with those patients, who have absolutely no tears. So what would you suggest in those cases?
So there are basically two issues when you're looking at fluorescein or any of the stain for that matter. You need to have some amount of tears on the surface. So if you have a very dry surface and it is not taking up, one option is to just put the drop at the upper fornix. So as it moves down with gravity, it will try to stain. You might want to use additional drop to kind of stain it, but then using it in the upper fornix will probably help us identify it better.
Maybe just putting one drop of anything, like maybe even although the lubricating drop can also be put in that, so that, because many times in these cases, even for the inflammatory mediators detection, they say that you can put a little droplet so that can collect the inflammatory.
Collect them. Yeah. The only thing is I wouldn't want to put lubricating drop because that will alter whatever tear film you're seeing. But when it is so dry and you can actually see the tear meniscus height is low or your Schirmer's is almost zero, so you know what the severity is. All said and done, there's no one test which is going to completely give us a diagnosis. You still need to look at the holistic approach with respect to Schirmer's or a tear meniscus height along with fluorescein patterns. Even though the Asia Dry Eye Society gives us guidelines in terms of patterns, it's not so easy to identify it because there will be overlap of patterns, because it's not a pure aqueous deficiency, mucin deficiency, or evaporative disease that we do. We see always a combination. So it's very difficult to identify it and say this is there. What I have clinically felt is the important thing is to see the movement of fluorescein up, which to a large extent tells us how much of aqueous is there. If the movement is less, then there is already an aqueous tear deficiency which is there. Apart from that, actually looking at the meibomian expression and the amount of glands which are expressing meibum and the consistency of meibum also tells us some extent about the, along with the breakup time, gives us some idea about the evaporative dry eye disease. I have not focused at any of the equipments in this talk because this was not the scope of the talk. So even for basic general ophthalmologists, just a bare minimum Schirmer's and fluorescein staining and evaluation of the lids and the meibum expression to a large extent gives you an idea about the dry eye state as such. Certain patients, yes, you might want to corroborate with equipment to have a diagnostic value. Okay, this is your lipid layer thickness, this is your gland dropout and stuff like that. That if you have the equipment, great. But if you don't have it, at least this basic clinical evaluation in 5 minutes itself should be able to help you diagnose and treat dry eye reasonably well.
Yeah, so I think for beginners, I just wanted to make a point. There's something called quenching of fluorescein. So basically in very severe dry eye, we end up putting more fluorescein dye and there is no diluent there. So everything looks black actually. And then when you put a lubricant or something, the whole thing looks, there's too much of fluid, or then, so we need to put very small amount of dye. And as you said, maybe extra saline or diluent so that we have right amount of concentration of the dye. Otherwise we have too much of dye there and no fluid there to dilute it, and it becomes, difficult to analyze.
Similarly, in just to add, in patients with chemical injuries or where there's excess watering, sometimes the fluorescein doesn't take up. So if you're looking at a chemical injury patient, you might actually have to apply fluorescein a couple of times for you to identify the area of the defect. Otherwise, normally the first time the water dilutes the fluorescein, so you might actually have residents and fellows write that there is no conjunctival defect on the surface. And then you just put one more drop or wait for a few minutes and reassess, the outline of the defect is seen. So too little tears on the surface and too much tears on the surface are both factors that you have to take into account when you're using fluorescein on the ocular surface to identify any diseased state.
You mentioned about MGD not having SPKs. Can you just clarify, because some of these advanced MGD cases, they do.
Yeah. So see, the thing is, when you're looking at a pure MGD and you have the ability to produce aqueous, there is a natural reflex to increase your tears, and they will normally start blinking faster to prevent the breakup. So when you're looking at a pure MGD, so pure MGD meaning I'm looking at say somewhere around 30 or 40 who comes to the clinic saying I'm having difficulty or I'm having problems in the eye, and you do the Schirmer's value is 10 to 15. You're looking at the staining is not there, but your tear breakup is faster. Your meibomian gland either shows a dilated glands or the LLT is low. So those are patients where you will not see a staining. If you're looking at somebody who's say 60, 65, you rarely have a pure MGD component. You always have it associated with some amount of an aqueous tear deficiency as such. The staining comes only because you are not able to increase your reflex tearing to match the breakup of your surface.
Okay, so we move on to the next talk, and that is by Dr. Nikhil Gokhale, and he'll be talking about corneal epithelial regeneration, new avenue in the treatment of dry eye disease.
You can see my slides?
Yeah.
Okay. Thank you. I would thank Eye Bank Association and also Santen for giving me the opportunity, and thank all the chairpersons here and the co-chairman. Very good morning to all of you and also the listeners. So basically, I was given this topic of epithelial regeneration and how we correlate it in the setting of a dry eye management. So as Bhaskar showed, whenever we look at a dry eye patient, we put a lot of dry eye questions, or questionnaires are put in to figure out how much of dry eye problems are there. And then, as you can see, ocular surface staining is a very important parameter when we are trying to evaluate a dry eye patient. And the ocular surface staining can also help us to know how good or bad or how severe the dry eye is, and grade the severity of disease, and thereby also define the best possible management protocol for the given patient. However, we need to understand that there is a significant paradoxical disconnect between the signs, the symptoms, and the severity of dry eye. So we have a significant number of patients who may not complain much, but when you do their surface staining, they might show significant staining. Why this may happen? Possibly one reason may be that, as we know, patients with severe dry eye have a decrease in the corneal sensations and a decrease in the nerve density. So maybe they don't have the reflex mechanisms, or they don't have the signaling system to cause pain, and therefore they are a little bit more comfortable, and despite staining may not complain much. So therefore, to overcome some of these issues, we have to understand that ocular surface staining is a very important parameter which needs to be there, because and as Bhaskar has really shown us so well, that fluorescein staining can help us to show the extent of corneal staining and tell us how much the corneal surface has got affected because of the dry eye process. And as I told you, we can grade the severity of dry eye based on the extent of staining. And a quick fluorescein breakup time helps us to also understand. And the pattern of breakup, as Bhaskar already showed us, can also help us understand the type of dry eye that we are possibly looking at. So basically, in essence, it's a very critical test for looking at ocular surface damage. And I think when we are looking at dry eye management, we need to go beyond symptomatic improvement, which most artificial tears may give us. And we have to look at how we can promote tear film stability and improve the corneal wound healing. So basically, we know the punctate erosions are small areas of cell loss. what I want to highlight is that when you do a casual slit lamp examination, it is very likely that some of these fine punctate staining may not be seen unless you put a dye into the eye. So therefore, it's very essential that we do put a dye into the eye and examine all patients who may or may not really look like a dry eye or may not complain, but to complete our ocular surface examination, staining is essential. And of course, we know that mild dry eye may have staining which is limited to the inferior part of the eye. There are some forms of dry eye where you may have superior limbal staining. And of course, when the dry eye is more severe, we tend to get diffuse staining, and we may also see filaments along with the staining process. Depending on the etiology of the dry eye pathology, we have some forms of dry eye where we may see very significant amount of staining. There are other forms of dry eye which may not show a significant extent of staining, still are equally important. Now, how do we address epithelial problems in dry eye? So basically, we need to think of why are we getting these epithelial erosions. So one of the most likely cause is because of friction, because of lack of lubrication, and therefore there is a mechanical surface issue which is causing the epithelium to slough off. The other factors which we need to also look and not really overlook are some of these neurotrophic factors where we know there may be a decreased nerve density and which might cause a delay in the epithelial healing. Similarly, there will be a cytokines which are likely to cause cellular damage, which may be basically inflammatory in origin. And then we also need to look at the toxic effect of the medications and the preservatives that the patient is using. So these may be some of the broad factors which might cause epithelial erosions. And we'll try to focus today on the first aspect, which is basically the mechanical aspect. And to improve this etiology or this mechanism, we would have to use better lubrication and look at epithelial regeneration. When we have to address neurotrophic factors, we will have to think about neural regeneration and again how we can promote epithelial regeneration. Of course, anti-inflammatory therapy and reducing the toxicity of various medications are other mechanisms by which we can reduce epithelial injury in patients who have dry eye. So we are aware of the corneal structure. The epithelium has tight junctions, which is like a barrier which gets disrupted in patients with dry eye. And in chronic dry eye, we have a reduction in the epithelial, subepithelial, basal nerve plexus and density. And these correlate well with the ocular surface staining seen in these patients. So what does really happen when there is an epithelial injury? So we need to understand how does the epithelium normally regenerate to understand how we can make it regenerate better or how we can address the issue. So whenever there is an epithelial injury, it tends to trigger or cause a reflex in the corneal nerves. The corneal nerves then release several factors such as the nerve growth factor, the calcitonin gene-related peptide and substance P. And these in turn lead to a release of several growth factors like the epidermal growth factor, TGF-beta, hepatocyte growth factor and others. So these growth factors then cause a release of fibrin, fibronectin and hyaluronic acid. These then sit on the basement membrane or the damaged basement membrane, and they provide a scaffold on which the cells at the edge of the defect or at the edge of the injury start sliding onto over them. And we know that the transient amplifying cells and the are there in the different areas of the cornea along with the limbal stem cells which are there at close to the limbus. So this is how an epithelium would heal when there is an epithelial breakdown. And we are aware that hyaluronic acid is a very important factor for epithelial regeneration because it binds to a CD44 receptor, which is expressed by many cells and which gets upregulated whenever there is an ocular surface damage. And it provides hydration as well as enhances the corneal epithelial healing, typically following ocular trauma or surgery. So as I showed you, this picture shows you that when there is a cell deficient site, there is a release of fibronectin, which is expressed in wound cornea. So you will have an upregulation of the fibronectin expression, which forms a sort of a temporary matrix on which the cells can adhere to and then migrate and slide and sort of cover up the bare area. So this is the process of healing. Hyaluronic acid has a very important role because it is seen that when you add hyaluronic acid, there is a addition of the HA molecules to the fibronectin, and this further aids the healing of the epithelial defect or the epithelial layers. So basically, they both act in tandem. And then there are several experimental and clinical models to show us that when you have an epithelial defect and you add sodium hyaluronate to these, for example, this is a rabbit eye study, the epithelial defects heal faster, and therefore it shows that there is a beneficial effect and it promotes epithelial regeneration. Similarly, another study which was looking at various concentrations of hyaluronic acid, and they found that a 0.1% concentration or higher works well in promoting corneal reepithelialization. This particular study looked at, again, this is a clinical study where they were trying to look at the breakup time. So we know that the hyaluronic acid can improve the breakup time for up to 3 hours and can help us to understand the dosing schedule for a HA molecule. We know that hyaluronic acid is a sponge-like molecule which can hold up to 1,000 times more water than its own weight. So this sponge will then slowly release water into the tear film, which improves tear film stability for a fairly good amount of time and maintains the surface wettability. Again, studies have shown in Sjogren's as well as non-Sjogren's type of dry eye that sodium hyaluronate improves the symptom scores in these patients. So in essence, what we are trying to achieve by using a sodium hyaluronate is to convert an unstable tear film into a more stable tear film and prolong the tear film stability till the next dose of the drop goes into the eye. And by promoting epithelial healing or accelerating the wound healing mechanisms, we are having a combination of hydrating the surface as well as promoting the corneal epithelial healing. And therefore, we are able to provide a much superior symptomatic relief when we are looking at patients of dry eye disease. And also, it is definitely a great advantage when we are looking at patients who are post-surgical dry eye, which I think is a separate topic which will follow a little later. So where we have an epithelial breakdown created by a surgical incision, the comfort as well as the healing is something that gets better once we use a sodium hyaluronate in the form of artificial tears. And basically, I think with better understanding, better knowledge, and better use of pharmacology and surgical techniques, I hope that in future we see less of ocular surface staining in our dry eye patients and we are able to deliver better success and comfort to them. Thank you all for your patient listening. Thank you.
Thank you, Dr. Nikhil, for a very nice presentation on how hyaluronic acid is, very helpful in these severe dry eye cases in improving the ocular surface and improving ocular surface healing. And it has really, put a very good tool in our armamentarium to help the patients of severe dry eye. Any comment from any of the panelists?
I think I completely agree with you. Sodium hyaluronate has changed the way we treat dry eye, especially in moderate cases. Maybe in mild cases, we can still, moderate to severe cases, it has really helped in coating the ocular surface. And I don't know how many of us are using it as first line of treatment. Nikhil, what would be your call on that?
I normally don't use it always as a first line, and depends on what type of dry eye we are seeing. So if we have, say, a computer vision syndrome or somebody with, not a very severe dry eye, I would still use maybe CMC based eye drops. And but always patients who are not happy, not improving, or they're not comfortable, I would always offer them to try sodium hyaluronate based eye drops and see if it helps them. The other important thing is that, we should try and avoid using them every hourly, because there are some patients where the hyaluronic acid acts like a sink of inflammatory cytokines on the ocular surface. And therefore, sometimes I also combine this with, say, another medication like a CMC. So the HA goes maybe 4 times, 5 times a day. And the CMC, if the patient wants, say, something to be put very frequently, the CMC can go in a little bit more number of times. So maybe we should try to also combine different agents together to get more optimum benefit.
Dr.
Dr. Rekha Ganchand, I think, wants to say something. Dr. Rekha has put her comment on the. If
Yeah.
again, yes.
Yeah,
Dr.
basically, if the tremors are very low, can you use HA drops, or it's better not to use it? Can you hear?
Yeah.
Yeah, we are able to.
Yes, Nikhil.
Yeah. So basically, I think if we have very severe dry eye, possibly nothing works in those patients. So we need to look at options if we can do punctal occlusion or try to augment their tear film. And as I said, maybe we can use a HA 4 times and then add other molecules which could be used on an hourly or a 2-hourly basis or something like that, so that we have a combination treatment that we can try.
So basically, HA not to be used in very severe dry eye. It's better in moderate, from moderate dry eyes, it's better to use, and not to use more than 4 times a day, right?
Yeah.
So just to add a point, if I can.
Yeah.
So generally, the younger patients, primarily MGD related, who just want to have less installation of drops, because the tear breakup is definitely increased with sodium hyaluronate or with, say, a PGPG molecule as compared to just a plain CMC, unless you're using the gel formulation of CMC or FPMC. That group seems to be happier with sodium hyaluronate or the PEG PG. One, because it reduces the installation, and these group of patients probably are not as affected by the price difference between a CMC and the other molecules. You look at an older population, even though they will probably also look at the price difference between a CMC HPMC versus a sodium hyaluronate molecule. And just to add on the point, if you have a very severe dry eye where your Schirmer's is low, you are not going to be just labeling it with one drop. You will have to use a combination. So where you're using a combination, you might have to decide whether you want to use a CMC with a gel-based formulation to reduce your need for drops as much. The gel-based formulation will have issues with blurring. So there, combining it maybe with a sodium hyaluronate will probably give the ATD component will be by the CMC or HPMC, and to some extent the sodium hyaluronate might be able to increase the tear breakup time, so that we can reduce it. But it ultimately boils down to an individual patient centric thing. If a patient is comfortable with CMC, we don't change it at all. The patient is comfortable with hyaluronate, we don't change it at all. Because even with the DEUCE 2 guideline, at this point of time, we do not have evidence to say that one molecule is significantly superior as compared to the other.
Okay, so a lot of patients after surgery, they complain about some irritation and all that. So let's hear from Dr. Namrata Sharma, who will be talking about post-surgical dry eye and how to manage it.
So thank you, Rajesh. I would be talking to you about post-surgical dry eye disease, which is itself is a entity which is completely different. Now, Induced in its report on iatrogenic dry eye has talked about this, and iatrogenic dry eye, which occurs mainly because of any medical reason or any surgical reason, which can cause dryness of the ocular surface. So it can occur due to topical drops, it can occur due to various surgeries, and it could be because of all the surgeries that we undertake. It could be cataract surgery, which could be corneal transplantation, or lid and conjunctival surgery, glaucoma surgery, vitreoretinal surgery, strabismus surgery, and even intrastromal corneal ring segments. Now, I will be basically discussing two scenarios which are commonly encountered. One is post-cataract surgery and other is the post-refractive surgery. It is important to discuss the topical drugs which can cause dry eye, because sometimes either pre-operatively or post-operatively, we are using these agents, and when these agents are being used, the surgery will act as a trigger to further make this dryness of the ocular surface worse. So there are drugs which can induce dry eye themselves, so one has to be careful, which could be anti-allergic, antiviral, such as acyclovir. then even decongestants, myotics, mediatrics, and cycloplegics, which are also used prior to both the procedures, the cataract and the refractive surgery. And of course, the most notorious is the benzalkonium chloride and topical anesthetics, as well as topical ocular NSAIDs, both of which could be used either pre-operatively or post-operatively. Now, most often than not, especially the cataract patients, they may be receiving anti-glaucoma medications also. So beta blockers, all kinds of anti-glaucoma medications can induce dry eye, which includes adrenergic agonistic drugs, carbonic anhydrase inhibitors, cholinergic agents like pilocarpine, and all types of prostaglandins, including biometoprost, letonoprost, travoprost, etc. Now, this is what we can see in these cases, pre-operatively or post-operatively, especially when the patients are undergoing cataract surgery. Preservatives, there are a lot of work which has been published, and this is a good article to review about the preservatives which are there in the eye drops, especially the long-term anti-glaucoma medications. Out of all the preservatives, the benzalkonium chloride is the most notorious, and especially because the lipid layer gets destabilized by its detergent action, and there can be epithelial defects as well, and it has a detergent activity. And this is just to show at the molecular level how it acts. So this is the control group, and this is where benzalkonium has been used 0.01% and 24 hours later. So all the markers or all the inflammatory markers which are there by all these tests show that there is increased expression whenever the benzalkonium was being used in the cornea samples. And this is a study which was done in vitro. Now, again, if you look at the confocal microscopy picture, there is effect of benzalkonium on the nerves also. There will be increased number of dendritic cells, more neuromas, and the keratocytes will also become more apoptotic by the use of benzalkonium. Again, the microscope light itself can cause phototoxic effect, and this is again an in vitro study where the various intensities of light were used to expose the corneal tissue, and then wherever the light intensity which was used was more, there was devitalization of the cornea and epithelial cells, decreased goblet cells, and reduced mucin production. Now, the lid in the conjunctival surgery can also cause dry eye, and you're also exposing the lids with the help of the speculum in case of cataract surgery. Then, apart from this, there can be other surgeries also which can cause dry eye, and these are basically the same. One has to diagnose cases of dry eye prior to the surgery, and this can be used by doing various kinds of staining, which have been very nicely shown by Dr. Bhaskar. And coming per se to cataract surgery and dry eye, one has to do a lot of investigations, and ocular surface disease index, tear breakup time, and the Shermers are the ones which are generally undertaken. Although exact incidence in these cases is underestimated, but following cataract surgery, this can affect up to 1/3 of the patients. It peaks at 1 week after cataract surgery, and it may persist for months, and patients may complain of unsatisfactory visual recovery. And this, of course, would have effect on the quality of life. And this is just to show that all kinds of surgeries, whether it is ECC, ICC, phacoemulsification, or flax, will induce dry eye. And it is said that flax induces more dry eye as compared to phacoemulsification. And the incision size also matters. So it will be more with the ICC and ECC as compared to phacoemulsification, and more with SICS as compared to phacoemulsification. Now, this is just to show the prevalence which can occur after cataract surgery. And these are the various studies which I have highlighted that how variable these are. So in one study, 9% of the patients had dry eye 4 weeks after surgery, whereas the other one during the same time period had 31%. So I think a lot would also depend upon what the preoperative status of the patients is. And in another study which was done in India, 12 weeks post-surgery, almost all the patients had abnormality in the tear breakup time, Shermer, and the dry eye disease. And again, this was another study which looked at and said that at 3 months, 27% of the patients had abnormal parameters. Now, duration of the dry eye disease also will vary after cataract surgery. So 32% experience symptoms of dry eye disease up to 6 months post-surgery. And signs and symptoms of dry eye disease, they return to normal as per this study by Kohli et al. After 3 months. However, like I said, pre-existing dry eye disease will make a difference because it has also been shown that almost 70% of the patients would show positive corneal staining, and there would be altered breakup time of less than 5 seconds prior to cataract surgery. Now, the pathophysiology which are related, especially for the intraoperative factors which cause dry eye during cataract surgery, are because of the repeated drying and repeated irrigation. Then because of the preoperative use of povidone, iodine, anesthetics, NSAIDs, etc. Because of the phototoxicity and because of the surgical trauma itself, which occurs because of opening, and especially if you are doing flax, then opening of the flax incisions, suction ring, which can cause damage to the limbal stem cells and can cause, all these can lead to ocular surface trauma and lead to dry eye disease. Again, you are making incisions on the main wound, side port, and keratotomies, which are again causing, jeopardizing the ocular surface. So the clinical manifestations could be new onset of symptoms or worsening of the pre-existing symptoms in the form of ocular discomfort, foreign body sensation, transient blurring of vision, intermittent pain, intolerance to wind and light sensitivity. And I think these I've already talked about. We've talked about benzalkonium, which is notorious for causing the ocular surface damage. And this is just to show that there were studies which were done where HPMC coating was compared with the BSS irrigation, and results were better with the HPMC coating. And cases where non-aspirating speculum was used versus aspirating speculum was used, which removes the fluid from the ocular surface, the dryness was more with the aspirating speculum. So that makes a difference. And whenever the light exposure from operating microscope is there, then interleukin 1b incites inflammation and causes production of the reactive oxygen species, which reduces the wound healing and viability of the conjunctival epithelial cells, and hence the phototoxicity can induce dry eye. Now, like I was discussing earlier, following flex, it is more because of the increased overall surgical time and also because of the laser energy used. Because of the fact that you have to use topical NSAIDs because you have pupillary meiosis sometimes intraoperatively, then there can be alteration in the limbal stem cells and the conjunctival goblet cells because of the application of the suction ring. And suction can also induce hyperemia and inflammatory edema, which can adversely affect the normal secretion of mucin and increase the release of the lysosomal enzymes. Then epithelial and stromal trauma can occur both, which can occur because sometimes when you're trying to open the incisions, a Sinskey hook is used, and this can also exacerbate the dry eye post-operatively. Now, in these patients, it is also very important, especially because if you're doing premium intraocular lens implantation, because increasing patient and surgeon expectations both are there, and more so if presbyopic lens exchange is being performed. And the first refractive component of the eye is the healthy precorneal tear film, and it is especially imperative in patients receiving multifocal IOLs because any little bit of compromise also in the optics can jeopardize the post-operative results. So I think that has to be absolutely ruled out before doing a multifocal intraocular lens implantation. So because we've already discussed the factors which are responsible for dry eye preoperatively, intraoperatively, and postoperatively, it is important to screen these patients well based on his history, symptoms, check medications, what they are using. Also, if they are computer users, then there can be more incidence of dry eye and they should be counseled for the same. And rule out all the other systemic disorders also, which can cause dry eye, such as Sjogren's, rosacea, connective tissue disease, and hematopoietic stem cell transplantation. Then one has to evaluate the ocular surface as well as the adnexa by doing the fluorescein staining, breakup time, Schirmer, non-invasive test, and in some cases, mammography may be required, especially if there is a NGD. Now, ASCRS committee has devised a pre-operative screening algorithm, which includes a new questionnaire, which is speed 2 based on Johnson & Johnson inputs. And this speed questionnaire and technician performed objective, non-invasive point of care clinical diagnostic test of tear osmolarity, and MMP9 levels are the one which have been advocated by the ASCRS clinical committee. But I think in our kind of scenario, the tear breakup time, the Schirmer and the OSDI suffice very well preoperatively to rule out dry eye disease. And this is just to show the ASCRS clinical committee performer, which needs to be filled up, and the algorithm which they follow to see whether dry eye is present or not and how to address it. So the preventive measures would be that you have to optimize the ocular surface prior to diagnosing, prior to the cataract surgery. And surgical planning has to be done very cautiously. Intraoperatively, try to make smaller incisions, have shorter surgical time, reduce the microscopic light exposure and intensity. And postoperatively, use preservative-free lubricants, avoid epitheliotoxic medications, and treat the meibomian gland disease. So this is again just to summarize a summary of what actually I have already spoken to you in detail about. Now, this is just to show again that it is a cascade of inflammation, tear film instability, tear hyperosmolarity, and all these things, all the precautions have to be taken right from the preoperative evaluation until the patient follows up. Of course, if there is a dry eye disease which is there, then preservative-free lubricants have to be used. One can use sodium hyaluronate, as was very nicely talked about by Dr. Nikhil. And lid hygiene, manual lid compression may have to be done, especially if there is a MGD, or you may have to use other instruments or other methods of treating the meibomian gland disease, which are machine-based. And one can try topical cyclosporin post-operatively also in these cases. Coming to post-refractive surgery-induced dry eye, it is one of the most commonly reported side effects after refractive surgery, and is also a cause of patient dissatisfaction because it adversely affects the quality of life and may cause psychological trauma to the patient. Now, as far as the incidence is concerned, it ranges from 20% to more than 50% in patients who undergo LASIK surgery. And the dry eye signs and symptoms are found in half of the patients after 1 week, 40% at 4 weeks, and 20 to 40% after 6 months. As is logically understandable, PRK induces less dry eye than LASIK, and SMILE induces less dry eye than LASIK, which is attributed to the relative sparing of the more superficial nerve fibers in SMILE. Now, the risk factors for this in refractive surgery patients are Asian ethnicity, female sex, Schirmer preoperatively, which is less than 10, more so because they are on contact lens wear, intraoperative use of mitomycin C, especially when you're using this for higher amplitudes of refractive error, greater ablation depth, narrow flap hinge, is superior flap hinge also because the concentration of the nerves is more there, and relifting of the flap for the retreatment is also responsible for this. Now, the proposed mechanisms, like I said earlier, are because of reduced corneal sensitivity due to corneal reinnervation, because you have to create a flap and also do ablation of the stroma, reduced reflex tear secretion, and slow regeneration of the nerves, which generally takes 3 to 6 months. So when you're doing a flap, all these nerves are transacted, but when you're doing a SMILE, it is only very limited nerves which are transacted. And so that is why the dry eye would always be less with the SMILE procedure as compared to with the LASIK procedure. LASIK procedure would cause disruption of the intracorneal nerves, but because of the disruption of the intracorneal nerves, the blinking rate would also decrease, and this can have an effect on the meibomian gland secretion also. And plus, because you're using suction again in case of LASIK, so this can also, the suction itself can cause damage to the goblet cells, which can cause tear film stability. So all of them would lead to dry eye symptoms. So it is a mechanism which is more than one, even in cases of LASIK, which can cause dry eye. Now, this is a nice paper which shows confocal comparison of femtosecond LASIK with subbomin's keratomeduses as well as with conventional LASIK. And this is the picture of the same, just to show how it does take, this is the pre-LASIK picture and how there are hardly any nerves present, and all these post-op 1 month, it does take some time before the nerve regeneration actually occurs. This is at 3 months and this is at 6 months, and this is before the femtosecond LASIK, and this is before the microkeratome LASIK. So the nerve regeneration does occur, but if you compare this with this, it is less with femtosecond LASIK and more with microkeratome. It is more with microkeratome LASIK than with femtosecond LASIK. Then again, this is just to show the comparative outcomes of smile extraction versus LASIK. And if you see all the parameters again, the smile tends to cause less dry eye. The sensitivity tends to be better with the smile. And the corneal nerve density, the number of long fibers, branchings, etc., as assessed on Confo scan is much better for smile as compared to that for LASIK. Then again, in these cases, you need to preoperatively work up these patients well, look at the tear film meniscus height, the Schirmer test, breakup time, ocular surface staining, the meibomian gland itself, which can be done on a LipiView or on an autorefractometer, or even by ocular surface analysis or ASA. And management post-refractive surgery cases, I think, essentially remains similar to that of post-cataract surgery. That is, you have to use lubricants in these cases. In our center, for all cases who are undergoing either smile, LASIK procedure or PRK, we are giving routinely sodium hyaluronate lubricants, and we've been doing this for the last almost couple of years with good results. And preservative-free lubricants we only need to give when actually the dryness persists for a longer period of time. We've never had to give, almost never, except in few patients, had to give topical cyclosporin for dry eye after refractive surgery. Topical steroids, of course, we routinely prescribe after both LASIK and smile procedures. It is important, again, if you have meibomian gland disease, which is less if you see for younger patients who are undergoing refractive surgery, then we need to treat it with warm compresses, lid hygiene, antibiotic eye ointment, and oral doxycycline, and sometimes even thermal pulsation or intense pulsed light in chronic cases. But like I said, again, this is less for refractive surgery patients and more for cataract surgery patients. Of course, when nothing really works, then one needs to also resort to other agents like dietary alpha, omega fatty acids, or autologous serum drops, etc. But this is something which we've, in our experience, never had to give. So to conclude, the post-surgery dry eye has to be well recognized, but I think it is still underestimated. And pathophysiology is a myriad of various aspects, not only of denervation, tear film instability, inflammation, but also toxicity. And treatment should address not only lubrication, but also denervation, inflammation, and other components of this condition, as well as one should take prophylactic measures because we know what components of the surgical steps can cause dry eye. So thank you very much for your kind attention.
Thank you, Dr. Namrata Sharma. That was a wonderful, exhaustive coverage of post-surgical dry eye. Just a question for you. For LASIK patients, we normally do a pre-operative assessment of dry eye and then we proceed with the treatment. Since dry eye can be caused by any surgery and cataract surgery is the commonest ophthalmic surgery, would you advocate at least basic dry eye evaluation for all patients who undergo a cataract surgery, or would you say limited to patients undergoing premium surgery?
I think, Bhaskar, I would agree on one thing, that for premium intraocular surgery, it has to be given. But I think that is something which has been hyped more by the companies because of the acceptance of the premium intraocular lens. And although routinely, I don't think most of us do a dry eye workup unless we suspect clinically for our routine patients of cataract surgery. But I think that's a point really well taken, that ideally at least tear breakup time and Schirmer test should be routinely done for these patients.
Because the idea was basically, it is easier to tell the patient preoperatively itself that he or she has a bit of dry eye. So the acceptance of post-surgical dry eye becomes better. And for us to even understand the incidence of dry eye in that age group, pre-surgery and post-surgery, if we have some basic values before, it becomes a lot more easier. And that's the reason why various studies, because the definition is different and the parameters are different, you have varied ranges from 9% to 30% to 60% post-surgery. The other question was, for a post-cataract surgery, how long would you want to continue lubricating drops if you're giving the lubricating drops, or are you giving it on a regular basis to cataract surgery patients?
No, we are not giving on a regular basis to cataract surgery, only if it is indicated. Again, like I said, if you look at the literature says otherwise, but then there's so much of variation. Even for me to get what is the incidence and what is the prevalence, it was a tough task, because if you read one article, it will say from 30% to, even like I said, it's shown from 7% to 100%. Now, there's so much of variation that it is difficult to, kind of comment on what it is. And I think most of the data has been obtained from retrospective studies. Hardly any prospective studies of large number of patients who have been, who have undergone. I think that is something that we do not pay much attention to.
And anyone in the panel could comment on what are the post-operative medications that you would want to avoid, say, in a patient with dry eye who undergoes cataract surgery? Is there anything specific that you would want to put those patients on?
Bhaskar, actually, least medication is always better. A prolonged use of NSAID and steroids both are troublesome for the ocular surface. So this is one point. Frequency, we unnecessarily add on so many medicines with higher frequency. So that also disturbs the surface. Lysozymes are destroyed. So chances of gaining dry eye is more. Patient's hygiene is also affected. So I believe that least number of medicine with least frequency is very good. Regarding the incidence of dry eye, I would like to add that being in Delhi and North India, we are too dry. Not in the true sense, but as the number of dry eye patients is very, very high in Delhi and North India because of extremes of the weather. So Namrata sees maximum number of dry eye cases as compared to Bhaskar, because that humid tropical environment is seashore is very much different. In Calcutta, the number of dry eye patient I used to see was hardly less than 10% or so as compared to in Delhi. And the biggest culprit is computer vision syndrome, pollution, and over and above the glaucoma medications and surgical procedures. Glaucoma medications are real bad bug for dry eye incidence and discomfort to the patient. Regarding the pre-operative assessment, at least we should see the lid margins and the thermal test for any surgical procedure, whatever we are going to offer. Because the patients, not only the quality of vision is affected, but the quality of life is equally affected in post-operative period if they have the dry eye. You have to warn them that this is going to happen. And on the lighter part, Namrata, you are a secretary of AIOS and UVI. If you keep on adding the flex and premium IOL to discourage, then how will we run our societies?
Right.
I think Dr. Rekha had a point to make.
And we are contributing to dry eye by doing webinars after webinars and, looking at the computers.
So you should have a virtual cocktail after this seminar.
Yes.
I think Dr. Rekha wanted to make a point on the use of NSAID. Dr. Rekha, you want to mention it?
I think it's better to avoid in dry eye patients as it will worsen. And even nowadays, most of the steroids are in combination with antibiotics. I think that also we need to avoid using. Better to use a plain steroids.
Yeah. So basically, you don't want to overload the patient with too many medications because that will damage the surface. At the same time, you want the patient to use medications which is required definitely for the post-surgical healing. And in a dry eye patient, you would want to avoid the use of NSAID as much as possible. If that rare case that you have to use it, you might have to keep him or her in a little bit more closer follow-up period as such.
One practical thing that I often see of general ophthalmologist, problem that they encounter is when the patient with their IOL doing fine suddenly comes up with some irritation and redness. they always ascribe it to maybe some anterior chamber reaction and actually step up more medications, including NSAIDs and things like that. So that is where I think, again, putting a fluorescein and seeing whether it's really inside the anterior chamber or on the surface is very important, because these patients then actually rapidly worsen and then they reach a cornea surgeon's referral is required. So I think we need to carefully examine when a patient becomes has an irritable eye after surgery, after a few weeks especially.
So I think we can proceed with the next talk,
Yeah.
Dr. Amit.
So next talk is by Dr. Bhaskar Sreenivasan, and he's going to be talking about dry eye disease treatment strategy for corneal epithelial damage and tear film instability.
I'll just share my screen. So basically, I would like to thank Santen for the slide deck. So I'm going to be speaking on the treatment strategy if you have epithelial damage and tear film instability, and how addressing these two parameters are also of importance when you're tackling dry eye. Part of the slides would overlap with what Dr. Nikhil said, just to reinforce the concepts more for the listeners. So when you're looking at dry eye, you have certain risk factors which causes tear film instability, and this leads to epithelial disorders, and this forms a vicious cycle. And somewhere we need to break the cycle to attain a stable ocular surface and to attain patient comfort. So like when you're looking at a dry eye patient and you want to treat it, you want to make the tear film stable. If you want to symptomatically improve the patient, and if there are any epithelial issues, you want to address that. So these would be the core that you would want any treatment to do. And if you're looking at a treatment option for dry eye, you have n number of options. So you could look at decreasing inflammation with steroids, topical immunomodulation. You could look at tear supplements. You could look at biological substitutes. You could look at reducing the evaporation. You could look at tear preservation strategies or tear simulation strategies, especially with the use of cyclosporine, lifitegrast, or even a P2Y2 agonist, which is not available at this point of time in India. So you have various strategies, and you would need to know where to position your treatment strategies. And DEUCE has given us some kind of a guideline in terms of what is the disease severity and where you would use the lubricating drops, where you would use anti-inflammatory medications, where you would go for surgical measures. So if you have a level 1 dry eye, the first step would be educational and environmental modifications. You can use any lubricating drops as long as it's only not on a regular basis. Even once with preservatives are fine if it is only for a couple of days time. But if it is on a regular basis, or if you have what we call as a level 2 disease, you would look at lubricants which are either preservative free, or they have the disappearing preservatives or the safer preservatives as such. You would be looking at addressing the MGD if they with IPL or LipiFlow if they have that, or you'd be looking at immunomodulators like cyclosporine or lifitegrast in this group. When you're looking at a level 3, you're probably looking at either using a scleral contact lenses, you're looking at permanent punctal occlusion, and at a level 4 disease, you're looking at surgically managing the complications of the dry eye disease state. So either by doing a tarsorrhaphy or by doing an amniotic for an epithelial defect which is not healing. So you need to position your medications based on the severity of the dry eye disease. So when you look at, say, this patient who has had a cataract surgery, she was a patient of Sjogren's syndrome, and post-cataract surgery, she presented with this kind of an ocular surface with a non-healing epithelial defect. She was already on a lubricant. She has undergone LipiFlow. She was on topical steroids. She was on topical cyclosporine. She had already had smart plugs put in both the eyes. This was the right eye of the patient. You can see the amount of staining of the ocular surface. You can see the defect which is not healed. It's been close to about 2 months post-cataract surgery, and that's caused a residual scar on the cornea. And the other eye of the same patient, which is less affected, but again, even this has a fairly severe ocular surface staining affecting the vision. Now, when you have such severe dry eye, you need to take the next step. So this is already a level 4 disease where you would want to do something more for the patient. So we went ahead and did a punctal occlusion. The smart plugs was there only in the lower puncta. We removed that, did a complete punctal occlusion for both the eyes. And post-cautery, even on day 1, the surface is a lot better. The defect has almost healed. And the defect in the left eye, the surface is much better. And even in the right eye, the defect had almost significantly improved in just 1 day. And the vision improved from 3/60 to 6/24 in the right eye and 6/18 to 6/9 in the left eye. So when you're looking at a very severe disease with epithelial surface disturbance, you might want to take the next step and manage the patient either surgically, or the other option in this case would be to use something like a PROS or a Boston scleral contact lenses to improve the ocular surface. Now compare this with this kind of a patient who is a 65-year-old lady who complains with irritation. If you look at the eye doesn't look too inflamed, but the tear meniscus does show that the tear meniscus height is low. The ocular surface staining is only +1, but the tear meniscus height is less. The tear breakup is faster. The lipid view shows up a value of lipid layer thickness, which is less. So this patient has both a component of an aqueous tear deficiency and a component of meibomian gland dysfunction. The level of severity is probably level 2. So here you're going to be looking at treating the aqueous tear deficiency with lubricants and treating the meibomian gland dysfunction with IPL or LipiFlow. Now, when you're looking at treating the aqueous tear deficiency with lubricants, the most important question is which tear supplement would you choose? There are myriads of tear supplements which are available in the market, each company claiming that their molecule is better than the others. So what decides our choice? It depends on the severity. It probably depends on the amount of times that the patient needs to be using the medication. It depends on the residence time of the molecule on the ocular surface. It depends on the blurring that the molecule causes. It depends on the patient's sensitivity to the preservatives in the molecule. It depends on certain attributes of the molecule that might help the proposed epithelial healing issues or the anti-inflammatory role of certain molecules. It primarily also depends on the patient's experience with the molecule. If the patient is reasonably comfortable with a particular molecule, you might just continue with it, no need of changing it unless the ocular surface warrants an addition or a change of medication. And it primarily also depends on the clinician's experience with different molecules. So coming to the part where I'm going to be talking about sodium hyaluronate, primarily higher dry from Santen. So it's a 0.1% drop. And basically, how does sodium hyaluronate help in a dry eye? Is it basically improves the tear film stability and it stabilizes the epithelium. So unlike artificial tears, which only replenish the tear volume, here it also has corneal epithelial healing issues, as was very well mentioned by Dr. Nikhil in his talk. So when you're looking at putting sodium hyaluronate on the surface, it aids the retention of the aqueous and the mucin on the surface. So when it stays on the surface, the blink induced shearing stress on the epithelium is reduced. If the epithelium is stable, the tear film becomes stable. And since it is able to hold on to the tears for a longer period of time, it improves the ocular surface stability and it improves the lubrication of the ocular surface. The molecule itself can bind to around 6,000 times its weight of water molecule, and it has a longer retention on the ocular surface because it binds to the mucin, increasing the wettability of the cornea, and the viscoelastic properties also are quite optimal. So it doesn't cause as much blurring as some of the other thicker gels would do. Coming to clinical studies on the efficacy of sodium hyaluronate in improving the tear film stability. So if you look at this study, which looked at what is called as the breakup index. The breakup index is nothing but the breakup point when you are after installation of the drop versus the breakup time before installation. So they've compared CMC with sodium hyaluronate, and if you look at the first 20 minutes, probably both work similarly. But beyond that, the tear film is kept stable for a much longer period with the sodium hyaluronate molecule as compared to a CMC based molecule. So this tells us that the tear film is stable for a slightly longer period of time. And if the tear film is stable for a longer period of time, the number of installations that you would want with this molecule is going to be lesser. This looks at the vehicle and the sodium hyaluronate, and compared to the vehicle, the molecule itself increases the non-invasive breakup for at least 3 hours. So this tells us that you would probably want to dose this maybe about 4 to 6 times in a day generally, and that should be sufficient. So when you look, the next aspect is looking at the epithelial healing and corneal wound healing measures, and what are the results that we have with respect to this. So when you look at sodium hyaluronate as a molecule, it binds to the fibronectin, as was mentioned by Dr. Nikhil, and then the cells migrate over it. And then once the cell layer is formed, then it helps in proliferation of the cells, and then it helps in cell differentiation. So effectively, it helps in all 3 stages of epithelial regeneration: migration, proliferation, and cellular differentiation. So when you're looking at lab models in this in vitro model where you have the epithelial culture and you've used the sodium hyaluronate molecule, it reduces the epithelial defect much faster as compared to a vehicle. When you're looking at the effect of the healing with respect to other molecules like chondroitin, chondroitin sulfate, keratin sulfate, heparin sulfate, again, it seems to promote the epithelial regeneration faster. When you're looking at experiment with rabbits with two types of injuries, whether there is an injury of the basement membrane or there is or we are just peeling off the epithelium without damaging the basement membrane, and they have looked at the vehicle sodium hyaluronate of different concentrations, 0.1 and 0.5 in the first part, and 0.1, 0.3 and 0.5. They found that any concentration more than 0.1 stimulates healing regardless of the presence or absence of the subepithelial basement membrane. So compared to a vehicle, a 0.1 definitely improves it. The difference between 0.1 and 0.3 was not very significant as such. So to conclude in this particular study, they said that the corneal epithelial healing, both the extension, cell division, proliferation and differentiation all happen with sodium hyaluronate, and sodium hyaluronate promotes wound healing at an earlier stage after damage of by the trauma, and it helps in extension and migration of the corneal epithelial cells. And 0.1% was effective for mild damage even when there is a relatively intact or there is a damaged basement membrane. So when you're looking at patient-related outcomes, you're looking at, say, symptomatic relief, and this is what they looked at, the ocular comfort index. So they looked at dryness, grittiness, and stinging as a composite number. And if you look at day 0, day 35, day 84, there is a constant improvement of the symptoms of the patient across the varied time frame. When you compare with the sodium hyaluronate with the CMC, the improvement in symptom score is much better with the sodium hyaluronate molecule as compared to CMC. When you're looking at ocular surface staining, at the same day 84, there's about a 50% reduction in staining with a CMC, and there's about a 65% reduction in surface staining using a sodium hyaluronate molecule. So both symptomatology wise and ocular surface staining wise, compared to CMC, the sodium hyaluronate molecule seems to be performing better as far as this study is concerned. So when you look at a clinical situation, where would you want to use sodium hyaluronate as a molecule instead of just a routine lubricating drop? Would be anywhere where there is, in addition to a decrease in tear production, an epithelial damage. It could be because of various reasons. It could be because of surgery. It could be because of trauma. It could be because of contact lens wear. It could be because of diabetes. Wherever the epithelium is a little bit unhealthy, sodium hyaluronate probably would score a little bit better as compared to a routine lubricating drop, which doesn't have that effect. So in summary, sodium hyaluronate addresses both the layers, the aqueous and the mucin layer of tears, because it is able to retain the mucin and it is able to retain the water on the surface for a longer period of time. It has corneal wound healing and helps in corneal epithelial regeneration as such, and it promotes tear film stabilization, promotes faster wound healing. It provides a longer retention time as compared to the other tear molecules that are available, and it improves patient symptom both over the short term and the long term period, and it may offer a better option as compared to its competitors. Thank you.
Thank you, Bhaskar. I think that was an insight into, when we have to use sodium hyaluronate and how it works. Now, do you think sodium hyaluronate, it's a little difficult question, but do you think of all companies and of all brands is same, or do you think there's a difference between them?
That's a tough one. I mean, we do not have evidence to actually look at one brand versus the other. Nothing available in literature. So to a large extent, it goes on what the person is comfortable with. Now you have two options, whether you want to use sodium hyaluronate alone or you want to use sodium hyaluronate with some of the others. So there are companies where you're using sodium hyaluronate with say trihalos or with molecules to improve the epithelial health in terms of the osmoprotectants. But there's no study which clearly proves superiority of one over the other. The use of preservatives again is something that is always in our mind. As far as higher dry is concerned, they have, even though they have the preservative back, the type of back 12 is supposed to be epithelial friendly. It is not supposed to have as much of epithelial toxicity as we label all back residues to. So I don't think we need to be too worried about that part as far as higher dry is concerned. But I don't think we have enough literature either in clinical practice itself to compare one sodium hyaluronate molecule with the other. You would want to trust the company which makes it, and that would probably be the thing, because that only assures the quality of the product is maintained across all batches.
Nikhil, your thoughts on it?
I was just thinking, like, does the a lot of company representatives tell you that the source of the sodium hyaluronate from where they're getting? So how does that actually? Is there any difference? I don't know really, but theoretically or
theoretically, it would depend on the purity. But again, like I said, it depends on the ultimately we are dependent on if you're using it for surgical purpose. If you're using a sodium hyaluronate for surgical purpose, you do see some brands having an absolutely quiet eye, some brands having a little bit of inflammation. So there is some issue with the processing of the molecule and making it in that particular thing. So the bottom line is still going to be how comfortable you are with the production and the maintenance of quality control and the checklist of that particular company with respect to that particular molecule.
I think the glaucoma people have done studies, where they've compared generics vis-a-vis, non-generics, but we have not done this study where we've compared these molecules generics. So I think that is something which should be done, either to prove or disprove.
The advantages for glaucoma, the target endpoints are very, very crisp.
Yeah.
For us, that becomes a major disadvantage.
So with this, we come to the last talk, and from epithelium, we move to the endothelium now, which is also one of the most important components in eye banking, and none other than Dr. Sunita Chaurasia from L.V. Prasad Eye Institute, with loads and loads of experience on endothelial keratoplasty as well as eye banking, who would be talking to us about the novel endothelial therapeutics and expanding roles of eye banking.
Yeah, thank you, madam, and enjoyed all the presentations. And as you said, from everything is connected in the eye. So from epithelium, we'll move to endothelium and look into how the novel endothelial therapeutics are influencing our practices in eye banking and corneal transplantation. My slides are visible?
Yeah.
So looking into first, what is the kind of burden of endothelial diseases? Common cause of corneal endothelial diseases are one common cause of corneal blindness. And if we look at it into the statistics of transplants, 50% of the transplants done in US are for endothelial diseases. Looking into the Indian context, as per the EBS statistics of before pre-pandemic, 80% were PKs, 13% were endothelial keratoplasties, and 6% were anterior lamellar keratoplasties. In the RIB data, R was more towards 30% transplants were more for endothelial diseases. So this is the recent indications of endothelial keratoplasty. As we studied from the recent years, it was found that the corneal edema post-cataract surgery was the most commonest cause, 50.5%. Endothelial dystrophies accounted for the next common, and failed grafts were the next common in line, the third commonest one. Amongst the endothelial dystrophies, the commonest which was seen was Fuchs endothelial corneal dystrophy. This is just looking into the spectrum of endothelial dystrophies, not particularly related to transplant. So in FECD was the commonest one, followed by congenital hereditary endothelial dystrophy. We all know that the FECD occurs in various forms and has several variants. We looked into how many of these presenting at the institute landed up with transplants. So we found that 10% of FECD eyes required corneal transplants. And we also looked at how many patients of FECD who had only cataract surgery landed up with transplants in the subsequent years. We found that of those who undergo cataract surgery in FECD, 10% may need keratoplasty after a period of 2 to 3 years' time. So when we look at the management of endothelial diseases, DSEC and DMEC are the current standard of care for endothelial diseases. And there are several alternative strategies which are now evolving, and some are also in practice and evolution. So when we have these very good vision gratifying surgeries, what is the driving forces for these newer therapies? So first and foremost, there is a need for minimally invasive therapies. Secondly, the reason for having these is because the reason is for the global shortage of the corneas, and thirdly, there is a requirement to have transplants which can have minimal risk of rejection in high-risk keratoplasty. So this reduces, further, there is a need to reduce the dependency on using medications for long-term and to alleviate the complications which are related to steroids. And also we have seen in the pandemic times how the eye banking had suffered. So these could serve as potential alternatives in the unprecedented times, such as what we saw in the pandemic times. So what are the newer therapies which are currently being used, and some are in evolution? First and foremost, the Rho Kinase Inhibitors are very popular these days for various, not just for glaucoma, but also for some of the corneal endothelial problems. Desmiture stripping only with or without the use of Rho Kinase Inhibitors, cultured endothelial cell transplantation, use of artificial endothelial implants, and then the last three, the endothelial stem cell regeneration, they are still in the lab stage, and genetic approaches and pharmacotherapies are to add to the list. The Rho Kinase Inhibitors are basically protein kinases that regulate the cell size and shape through the action on cytoskeleton. The initial one, the Y27632, was known to have protective and pro-proliferative effects on regenerative medicine. Subsequently, netarsodil, which was popular in the US as Ropressa, and Ripasodil was popular in Japan as Glanatec, and in India it was approved for in 2019 after DCJ approval and has been in use since then. Now, Rho Kinase Inhibitors have been found to be used in Fuchs endothelial corneal dystrophy. They have had some application in other causes of corneal endothelial decompensation, and also have seemed to have some endothelial protective effect in the corneas with low endothelial cell density. This is the literature which is as per the application of Rho Kinase in various conditions. We have one more, we were all aware, and there was some literature in the past also which talked about desmitorexis and subsequent corneal clearing. Now, DSO became popular after in the last decade, and here it was seen that in cases where you have in central guttae, you remove the desmus membrane in the center 4 millimeters, and you see the corneal clearance happening after a due course of time, and this is mainly because of migration of the peripheral cells to the central cornea.
I think
in those cases where the peripheral endothelial cell density is good, in those cases of FECD where the cell count is at least above 1500 in the peripheral part of the cornea. Center part may not be reliable because quite often in Fuchs we don't see the central corneal endothelial cell density is not applicable because of the desmus membrane thickening. This cannot be an option in those with diffuse endothelial cell loss, such as with PBK, where the peripheral cells are also compromised. Now, this is just a table showing the various studies available. What is common to most of these is that many of these are restricted to limited number of eyes, and most have been used in Fuchs endothelial corneal dystrophy with a variable follow-up of 6 months to 5 years is the only study which is in 2020 by Melanie et al. But overall, the outcomes are reported for short-term for 6 to 12 months. The success has been variable and dependent upon several factors, and that is what is the reason why it is not a standard of care in the present times. With respect to use of Rho Kinase Inhibitors, I would want to share some of my experience. I have used it in some cases with focal corneal edema, in some cases of Fuchs endothelial corneal dystrophy, and found some bit of success in clearing of the cornea. In Fuchs endothelial dystrophy, the early variant which presents in patients with younger age, 45 less than 50 years, where they don't have much of symptoms, and some patients who complain of early morning symptoms, it has been known to be somewhat improving the symptomatology of the patient. It can also be used in little older patients where the cornea is compact with no epithelial alterations and not much of DM thickening. It is also useful in post-PK eyes where the rejection has happened and subsequently cornea is in a stage of clearing. Now, this works probably because in those eyes like keratoconus where the recipient endothelium is healthy, there's a potential for the peripheral cells to migrate in these cases. It can also be used in morbid patients when general condition does not allow for a transplant surgery. Moving on to the next one, the cultured human endothelial cells. when we have donor cornea, why do we need to culture the cell? This is potentially because with one donor cornea, there's a possibility of treating 8 eyes using a single donor cornea, and this can address the shortage of corneas. And secondly, the other thing is because these cells are likely to be least immunogenic on the cornea. So chance of rejection are going to be very minuscule with this therapy. So what does it involve? It involves 3 critical processes: isolation of human endothelial cells, preservation, and expansion into sheets. The isolation of human corneal endothelial cells is pretty much similar as what we do with the DMEC roll preparation, and subsequently the Desmiture membrane from the endothelial cells is treated with collagenase and trypsin EDTA combination to loosen and detach the cells from the Desmiture membrane. The cells are pipetted and then put into culture in the endothelial culture medium, and followed by preservation of the cells. But this is just to show the successful endothelial culture from a 1-week donor, and this shows the various stages under the force contrast microscopy, showing 4 days, 9 days, and 12 days stage. The cultured cells can be placed on biological scaffolds which can be transplanted similar to DSEC and DMEC, or else there's a possibility of having a direct injection cell therapy, as was shown in Kinoshita's paper in 2018. So cultured endothelial cell transfer was done. We did in 1 eye as a pilot study where we had a limited success. However, the patient did well for 3 months, followed by edema after the 3 months time period. There are other modalities of managing endothelial diseases. One such is, which is upcoming one, is the artificial endothelial implant. This is basically a transparent disc that blocks the aqueous humor coming into the stroma, as a result of which you have a relative dehydration of the corneal stroma. So this is a disc measuring about 6 to 8 millimeters, and this is one patient where we did for a patient who had a total locomatous optic atrophy and bullae. The patient was symptomatically relieved. However, because the patient did not have much of vision, there was no potential, but for symptomatic relief, this procedure was done in this patient with good outcome. The other therapies which are coming up are these are again in experimental stage and stage of research, is the endothelial stem cell regeneration. It is known that there's a transition zone between corneal endothelium and trabecular mesh, which can serve as potential reserve for endothelial stem cell regeneration for various conditions. Gene editing is one more potential therapy to may be applied particularly for Fuchs endothelial dystrophy. And there are some other pharmacotherapies which have been applied particularly in CHED, where antioxidants and NSAIDs have been tried to improve the corneal detergescence. There are other pharmacotherapies also which are being tested and tried. However, these are not in clinical practice as of now. So with respect, when we to these interventions, when we have these non-invasive therapies coming up, and or at least the minimally invasive therapies coming up, why is it relevant to the eye bank? So this question keeps coming up often. If these therapies get perfected, is it that the dependency on the eye banks will lessen? So answering this question, when we look into the evolution of eye banking, eye banks evolved as institutions that were responsible mainly for collecting, processing, and distributing corneas for corneal transplantation. However, when the new techniques came up in corneal transplantation, eye banks rapidly adopted to the new change and were involved in pre-cut procedure, distributing the pre-cut tissue for both for DSEC and DMEC. And looking into the way the eye banks have evolved in the past, it is quite possible the future role of eye bank may be into the delivery of these translational research technology also, and eye banks may evolve into tissue and cell banking. So what can be, we're looking into the crystal ball, probably if these therapies come into practice for for general management and become the standard of care, it's likely that the eye banks are likely to adapt and evolve to meet the need of the changing times. Thank you very much, and I thank Santen and EBI for giving me this opportunity.
I think that was an excellent talk, Sunita, into futuristic of how we'll have to tackle endothelial cells. It's sometimes you really wonder if in your lifetime we would be able to see a complete whole grown cornea, and we've been hearing about it since since the time we entered ophthalmology, that there is a paucity of good quality donor tissue. There is a paucity, but let's hope that something happens during this time only. Any comments from the other panelists?
A lovely talk, Sunita. Just wanted to know the patient of glaucomatous optic atrophy that you put an endothelial a plastic disc kind of a thing. How long does it take for the edema to kind of clear, and what was the follow-up of that patient? think we've lost her.
So this patient has a follow-up of 6 months now, and edema, then some bit of fluctuation is seen, and it stabilizes after about a month. This was just in 2 patients we had. I mean, it's a part of the clinical trial now. The application is more into the eyes with the potential. So, but it seems to work pretty well. But however, there are certain limitations, and some case-to-case based variations might be there.
Any other comment, Nikhil?
I just wanted to also ask, like, in the institutional setups or in AIMS, like, when do you use Rho Kinase Inhibitors? Because now I find all the general ophthalmologists are blanketly using these drops, and many patients come actually with red eye, and then they come with epithelial changes because of these drops. So could you tell us what are your specific indications, so that we are clear about when to use or when it will not work, something like that? Can you guide us?
Yeah. So for me, the reasons for using Rho kinase inhibitors will be the patients who present who are having Fuchs endothelial dystrophy, the early age onset ones who tend to have a numerous guttae, but cornea is compact. They don't have any clinical edema. There are no subepithelial changes. They may occasionally have early morning symptoms, which is also not very consistent. So those kind of cases I have seen, they typically have improvement in the symptoms, and this is without using hypersol, any other sodium chloride preparation. I feel that when we have started this medication, they seem to have the symptoms have become a lot improved. Even in the other patients of older age onset, because those patients tend to have a more discrete guttae, confluent guttae, and some bit of thickened endothelium, thickened Desmiture membrane, but the peripheral cell count is good. They also tend to have some early morning symptoms. In those cases, we can specifically try that because it really helps to improve their symptoms. Patients of Fuchs endothelial dystrophy where the peripheral count has been able to give a good counts, reliable counts, those cases again, I don't usually typically plan them for combined surgery. I usually just go ahead with the cataract surgery alone, and sometimes if they have early morning symptoms, I've seen in the post-operative period, again, if you give this, like let's say if they have any symptoms 1 year, 2 years down the line, because of the patients who underwent cataract surgery with the evaluation that they may not need transplants, only a handful require transplant subsequently after 2-3 years period. So like let's say in 2-3 years period they come with some early symptoms, that would be again one guideline, one indication to start the Rho kinase inhibitor. I have also seen, and this is I don't say that I've seen in quite a lot of patients, but then I have recently seen few cases of rejection, which kind of did not recover completely. Specifically in keratoconus. So because I believe it's just working with the principle that because you have endothelial migration from the host bed, which are healthier, so probably your corneal clearing is quicker, and the rejection, like it has led to attrition of cells, but the overall visual acuity tends to get better even after rejection. So possibly these could be the indications for using this molecule. Apart from IOP lowering certainly does happen to the tune of 6 to 10 millimeters. We can try that in our post keratoplasty patients which are borderline IOP, rather than going them for glaucoma filtering surgery and other things which can further compromise the graft. So this can be tried as an additional anti-glaucoma agent for post-PK patients. So this would be the reasons for using Rho kinase, not particularly for DSO, which is not, I'm personally not too fond of it, but guess these would be there are limited indications where it can be used, and which is given some beneficial results.
If I could answer, Nikhil, basically the molecule has been tried primarily in Fuchs. So the idea of using it is primarily in patients where you have some amount of residual endothelial cells, which allows it to migrate. Rankedly using it for any corneal decompensation, especially if it's a pseudophakic corneal decompensation, you have probably destroyed so much cells that there are not going to be too many cells in the periphery. Those patients, if you use it, you tend to probably get that epithelial honeycomb kind of edema, and then the irritation because of the selective bullae that is formed. The redness is probably part of one of the side effects of the molecule itself, because they do have, even if they do respond, some people do have a little bit of congestion. I'm not sure whether it is to do with the generic version that we are using versus, the version that we are using versus the one which is used in Japan, because they have not mentioned about it as one of their side effects, but they use the preservative free molecule in Japan as such. What we have available here is with the preservative that is there. So it would probably you would want to be using it in Fuchs in patients with some amount of peripheral endothelial cells. It might work. The second would be I would probably look at if the patient is already on glaucoma medications and I have to do a transplant. We have very few anti-glaucoma medications which are safe in the transplant. So if the patient is on carbonic anhydrase inhibitors, then I might want them to shift. So that group, again, I might ask my glaucoma colleague to shift them to this molecule, because it might help in reducing the IOP also, and it might help post-surgery to kind of at least maintain our endothelial cell pool. Because the migration, the DSO principle is basically you are removing the unhealthy guttate changes, and the trauma induces the cell to migrate, and at that time you're giving the molecule to allow the cells to migrate a little bit better. So when you're doing a transplant surgery, and if the patient requires any medication for glaucoma, maybe using this to reduce the pressure and then doing the surgery might actually help establish your endothelial barrier a little bit faster. But that's just a hypothesis. It's not something which is clinically proved. But I would want to use it for glaucoma patients whom I'm doing a transplant or post-transplant if the pressure increases, rather than some of the other anti-glaucoma medications. Definitely, I wouldn't want to use a carbonic anhydrase in a post-transplant patient as such, and I would probably avoid a prostaglandin analog also as much as possible. So there, this becomes a useful tool.
I think there are no more questions. I think there are questions in the chat box, I think.
Yeah, so the one question was on whether you would use a fluorescein strip or you would use a solution. Fluorescein strip is preferred more because the solution can easily get contaminated with Pseudomonas. Even though you have studies or trials where they would give you unims and you can use it, but in a practical day-to-day working, the strip is a lot safer way. The only thing would be, caveat would be, try to use as minimal a drops as required. Try to be consistent in the amount of drop that you instill on the fluorescein strip. Shake it and then put as consistent an amount on the eye to be sure about your findings as such. The next question.
Then the question is when to avoid fluorescein staining in dry eye evaluation.
I think there's no specific contraindication to using fluorescein in dry eye patients, unless obviously you have a frank large perforation and the AC is flat. You don't need fluorescein in that eye, because you don't want anything to be going in that eye as such.
Then I think there is this one, posterior surface of the cornea like desec. What is the level of that? I think Sunita has already answered. What is the level?
One question was whether you would want to avoid NSAID even if it is used for a few times in a cataract surgery in a dry eye patient.
I think we would like to avoid, because NSAID is known to cause corneal melting, so it may compromise the ocular surface. I think all the questions are also answered. With this, we come to the conclusion of the webinar, and we would like to thank all the speakers today for a wonderful discussion and also for excellent presentations. From epithelium to endothelium, we would also like to thank our sponsors, Santon, for doing this for us. And we hope to have another one shortly, possibly in the next month. And I would also like to thank Dr. J.K.S. Parihar, our president of Eye Bank Association of India, for always being so encouraging and always being so proactive, and for allowing us to do, these webinars. Some of them are not directly related to eye banking, but they do have an important role to play, because eventually are dealing with the cornea and the ocular surface. Would like to thank Ganesh and Rakhi for organizing this, Mr. Rahul Jain from the audiovisual team, and Richa for coordinating with all of us from Santon. Sir, would you want to say something?
Yeah, definitely. This, I think I have learned a lot from each and every speaker. It was it's something very unique webinar which you have carved and delivered by Bhaskar, Sujata, Nikhil, Namrata, yourself, and great learning. And I would prefer that this webinar should be made available on YouTube for PG's orientation and understanding the nuances of management of OST. It's a really coming up subject with most challenges for all of us. And this, your efforts, is good for OSD Cornea Society, as well as to make our utilization of cornea in a much better way for keeping a better preoperative preparations and the post-operative management. Really a wonderful experience for me. And regarding your comments upon my contribution, I believe the president of the society has a constitutional right to act to preserve the constitution and promote the society. And all executive and all good powers as our constitution gives to the prime minister, I have to work under the guidance and advice of council of my executives and my secretary. I take it on that way. And we all are on the same board, because our aim is to just to see that our professional sphere goes very high. As Sujata has given us a lead and vision that what should be the future of the eye banking in our country. And I am very happy to observe it, and I'll give her this responsibility to start out more activities and incorporate in eye banking in EVI. Thanks a lot to each and everyone.
Thank you, sir.
Thank you, sir.
Thank you, everyone. Thank you.
Thank you. Thank you.